Juvenile idiopathic arthritis, or JIA for short, is a chronic autoimmune condition in children, and generally what it means is that they get inflammation of their joints, and that's the arthritis. The immune system is the part of your body that defends you, and what happens is that the body, instead of just defending you, actually attacks in JIA the joints, and that causes inflammation. The reason we treat juvenile idiopathic arthritis first and foremost is that you want to control the inflammation in the joint. If you don't control the inflammation in the joint, that'll continue and it'll destroy the joint. Once you destroy the cartilage, you can't regrow that. And so if children have damaged joints, they can have early osteoarthritis or be unable to move and have chronic pain. The other thing is, if you don't control the inflammation, it'll affect the growth of the bone, and children are still growing and developing. So initially the bone might and the joint might be larger, but later in time, once they reach maturity, they'll actually become shorter and smaller. Long term, it can affect the bone and the muscle, and particularly the strength of the bone. To some extent, this is related to the medication that is used, which is why we try not to use steroids for too long. This is also a reason why we encourage that children remain active. If they remain active, they can move their joints, they can keep their muscles strong, and they can keep their bones strong. But it is important that they have an adequate amount of calcium in their diet. One of the things we're most concerned about are actually eye complications. So children can actually have inflammation of the eyes, otherwise known as uveitis. And this occurs in at least a third of patients with JIA, which is why it is really important that patients actually go and have their eyes checked by an ophthalmologist regularly. The problem with having inflammation in the eyes is that in the chronic version is asymptomatic. In other words, children don't feel or notice anything, and it's only by looking in the eyes with a special test that the doctors can see inflammation. Then it can be treated. In terms of medications treating the actual inflammation, our first port of call is generally corticosteroids. The most common one we use is prednisolone. However, we use this in different ways. We can inject the steroid into the joint, we can give steroid by mouth, or we can give high doses through inserting an IV line. It would be our preference to use intra-articular injections, or otherwise steroid injections, as opposed to other medication, because there are fewer side effects. The more steroids you use and the longer you use it, the more likely the child is to have long-term effects. But generally steroids are like a bridging medication until we can start the other medications. Steroids work fairly soon after having been given, whereas the other medications take time. So the other medications we use, depending on how bad the arthritis is or what group they fit into, are what we call DMARDs. And these are just disease-modifying drugs. They do have an effect on the immune system. The most common one we use is methotrexate, and we use doses just to modify the immune system rather than completely suppressing in the immune system. These drugs take anywhere between 6 weeks and 12 weeks to have its full effect. It's also really important that we start these medications and ensure that the child's tolerating it, not only symptomatically, but also that we check their blood tests, that it doesn't affect their bone marrow and, for example, their liver. And our aim is really to induce remission and get control of the disease. The sooner we can do that, the better long-term outcome. The next tier of treatment would be biologics. They are very effective. They have revolutionized how we treat juvenile idiopathic arthritis. They work similarly in that they target the immune system, except that they're more specific and aim for a very particular protein as opposed to the generalized approach in the other medication. I understand from not only children who are patients but also adults is that the stronger formulation is actually very painful. However, they are excellent agents, and whereas previously we could say to parents we will be slowing down the process of damage, we know that these drugs are capable of switching off the process, and many of patients that we've treated with that have reached remission. But pretty much means that they have no more symptoms and no joint signs that we can pick up. More recent studies are showing that the sooner you get control and more aggressive, generally it appears that you get a better outcome. Once they start treatment, many children can behave as normal kids, can participate in activities. However, it is important that they are regularly seen, that they take their medication, but also that they've got the support around them and that people actually understand what it's like. With early diagnosis, pump treatment, and all the support, kids can do wonderful things.